Hello again from Axxess headquarters. This is Jennifer Gibson. I'm a registered nurse and I'm OASIS and Coding certified, and I'm here to bring to you today part 9 of our 12-part series called Navigating the Highway of ICD-10-CM. Our focus today is going to be coding those GI and GU conditions in home health care. Our objectives today, of course, are to understand why proper coding is important, to learn who's responsible for applying and assigning those diagnoses. We're going to study guidance for coding GI and GU diseases in ICD-10, and then we'll apply the knowledge we've learned to common home health scenarios. Now let's briefly talk about who it is that is supposed to know what's going on and assign the diagnoses on the OASIS. And if you want more in-depth teaching and training on this topic, as well as the guidelines and conventions for ICD-10 in general, you'll need to go back and listen to part 1 in the 12-part series, because we cover in depth the guidelines and conventions and rules for ICD-10 coding in home health. But according to that OASIS C1 guidance manual, we learn that the primary and secondary diagnosis selection must be made by the assessing clinician. And that clinician is expected to understand the patient's overall medical condition and care needs before selecting the diagnoses. So in other words, you can't start adding diagnoses before you see the patient. You have to really get out there and assess the patient fully, review the documentation, and then make your selection of the primary reason you're in the home and why you're going to take care of the patient, and then any secondary diagnoses as well. And those diagnoses are based on the assessment findings of the clinician, the medical record, and input from the physician. Now again, who selects the diagnoses? According to that OASIS C1 guidance manual, the assessing clinician should record the primary and secondary diagnosis name in M1021 and 1023, as well as in the other diagnosis slots like M1017 and the other parts that might ask what the inpatient diagnosis was. That's all the responsibility of the assessing clinician to write the name of those diagnoses in. However, the coder can assign the code itself after that assessing clinician has determined the primary and secondary diagnosis. So if you don't know the code number and you're out seeing the patient, it's okay. Just write in the primary reasons and sequencing, and then the coder themselves can write the code down for you. So if we're going to be doing the diagnoses, let's talk for just a moment about the criteria that should be met for the primary diagnosis that's selected. Number 1, that primary diagnosis should be the one related most to the current plan of care. And if there's more than one diagnosis being treated and to consider, it's the diagnosis that represents the most acute condition and requires the most services. That should be your primary diagnosis. In other words, it's the chief reason for home health. It requires the most intensive skilled services, and it's not a Z code unless absolutely necessary. When you're selecting a secondary diagnosis, you need to consider the following criteria. First of all, those are diagnoses that didn't meet the criteria for primary diagnosis. These are also diagnoses selected that are addressed in the plan of care, and they affect the patient's responsiveness to treatment and rehabilitation. And then you're going to list those in the order to best reflect the seriousness of the patient's condition and to justify the disciplines and the services provided. And by sequencing them in that way, you also have to follow the guidance as far as what goes first. If there's a code first, for example, you have to put that, although that may not be as acute a condition as what you thought. So again, you have a lot to figure out when you're doing the diagnoses. When it comes to actually coding itself, you want to start with the alphabetic index of your code book. Now, if you see in the alphabetic index a dash at the end of an entry, that means you have to have additional characters added on to complete that diagnosis code. And also, if you see guidance that says C or C also, you need to take that as a command, because there may also be information in a different entry that gives you more clarity or leads you to the correct diagnosis code in the other entry. Once you find the correct code in the alphabetic index, you need to always double check that in the tabular index. And in the tabular, you want to check for guidance at the chapter level, at the chapter block level, At the 3-character category level and then the final code level, there may be guidance in all of those areas. So now that we know some background information, let's go ahead and get into talking about gastrointestinal codes in home health and ICD-10 coding. Now, CMS told us way back in 2014 and even before that most gastrointestinal diseases are too acute for the home health setting. And they told us that in a final rule where they took the case mix points away from most of the GI codes. And that was way back in ICD-9. But those ICD-9 codes, when they translated to ICD-10 codes, they also did not have case mix points assigned to them. And those are things like bleeding ulcers and all kinds of GI problems, for example, GERD even, because CMS basically said these are too acute. We really don't do care for bleeding ulcers in the home. We may take care of them after they've been in the hospital for bleeding ulcers, but we don't actually care for a lot of obstructions and things like that in the home. So it doesn't mean that we're not supposed to code those problems, but you really need to understand when and how to code those. In other words, you wouldn't want to put gastroesophageal reflux as your primary reason for home care, because what are you going to do? Tell them to take their Pepcid and teach them to sit up for 2 hours after they eat and the proper diet? That's not going to take an entire care episode, and certainly shouldn't be the only reason you're there, right? That's not a really acute enough problem. And certainly if the patient has, let's say, a bleeding ulcer, you wouldn't want to code that, because surely you're not taking care of a bleeding ulcer unless it happens to be one of those where it just oozes a little bit and the patient's terminal and they're not doing anything else because they really have cancer and this is another condition. So again, all of that, you have to really know what CMS is talking about with reasonable and necessary and what is your true primary reason for care. All of that just to say that really be particular about what you code in the GI section. Now, the gastrointestinal codes are found in Chapter 11. Many of the codes in this category have extensive guidance at the 3-character category. So you'll want to look at 3-character categories such as K11, diseases of the salivary glands, K12, stomatitis and related lesions, K13, other diseases of the lip and oral mucosa, and K14, diseases of the tongue. Now, you'll see a lot of use additional code for alcohol abuse and tobacco use exposure or dependence, because most of the time those can increase the risk for having these types of issues. And if you're told to use an additional code and you don't do it, you're coding improperly, which is, again, all that reinforcement just to say that this is why we really should be coding from a code book and not looking it up online or just trying to guess from a general equivalency mapping and so on. Now, many of the other codes in Chapter 11 require additional codes to identify alcohol use and dependence. For example, the esophagitis codes at K20, the gastric ulcer codes at K25, the duodenal ulcers at K26, and peptic ulcers at K27. Also, your acute gastritis and alcoholic gastritis at K29.0 and K29.2. All of those codes, you'll notice there's guidance that tells you to use an additional code if the patient has had any problems with alcohol use or alcohol dependence, okay? Now, chapter block K40 through K46 are your hernia codes. Some things to consider when you're talking about hernias. Number one, you need to carefully review your documentation. You need to know the correct anatomical position, and you'll also need to know if that's an obstructed or non-obstructed hernia, and if the hernia has been surgically repaired and there are no complications, you're going to actually code aftercare in M21 or 1023 because the hernia has been taken care of. Now, you might put that over in 1021B, over in the second column to the right, the hernia, but you're actually there for aftercare after the hernia has been taken care of surgically. With enteritis, you'll also need to know if this is an infective or non-infective type. Infective enteritis most of the time is coded in Chapter 1, which is the AB codes. I think AB for antibiotics. Those are all of the germs and bugs and bacteria and all of that's in Chapter 1. If it's a non-infective enteritis, that's likely going to be coded in Chapter 11. And all of Chapter 11 codes start with K. I think K for kaopectate for GI. That's how I remember. In Chapter 11, you see more of the non-infective types, such as Crohn's disease, ulcerative colitis, and allergic or dietetic problems. All right, so when combination codes are found in this chapter, Chapter 11, you don't have to use additional codes in some examples. For example, at K58.0, you have irritable bowel syndrome with diarrhea. You don't need to add another code for diarrhea because it's already part of the combination code here. And that will apply to many of the combination codes unless they specifically tell you to use additional code to code something else. You don't have to do that. Your ostomy complications are found at K94. Those complications include things such as excoriation or denuding around the ostomy. Could also be infection of the ostomy site, hemorrhage, and other complications. Now, you don't want to assign a status code or attention codes, in other words, the Z codes for the ostomies, when you have those ostomy complication codes at K94. And that only makes sense because Z codes indicate routine ostomy care or just a status. And that's inappropriate when you have a complication because that's not routine, that's a complication problem. All right, let's talk a little bit about our genitourinary coding in home health. Most of the genitourinary diseases are found in Chapter 14. Those codes start with N. You're primarily going to deal with these types of diseases, things like chronic kidney failure at N18, urinary incontinence at N39, cystitis at N30, urinary tract infections at N39, and prostate issues are found at N40, N41, and N42. Now, there are many more specific types of urinary incontinence in ICD-10 than we had in ICD-9. For example, you have N39.3, stress incontinence, N39.41 is urge incontinence, N39.42 is incontinence without urinary awareness, N39.43 is post-void dribbling, N39.44 is nocturnal enuresis, N39.45 is continuous leakage, N39.46 is mixed incontinence, and then N39.490 is overflow incontinence. So you have many, many more types of incontinence to code. Now remember, your documentation has to support the diagnosis that you choose. So if you have a specific type of incontinence you want to code and you don't have documentation to back that up specifically, you will need to coordinate with the provider and query and get that information down in your medical records. Make sure you record to whom you spoke, their name and title, and the information that you received. And once you have that documented, you should be able to code that. All right, let's talk about prostate disorders. In ICD-10, just like in ICD-9, many of your prostate disorders are classified as to whether they have LUTS or not. And LUTS is lower urinary tract symptoms. Now, you're going to see guidance to use an additional code for what the lower urinary symptoms are, such as incomplete emptying, incontinence, straining on urination, frequency, urgency, retention, hesitancy, and weak urinary stream. When you're coding urinary tract infections, try and find out what the infectious agent is. In other words, what's the organism causing that infection? If you can get that within your 5-day assessment window, then you can certainly code that. If not, you'll just have to code what you have, because our coding guidance tells us to code to the highest level of specificity known. Okay, so your guidance at these codes for urinary tract infections will ask for that additional code to identify the infectious agent if known. All right, let's talk a little bit about chronic kidney disease, or CKD. Chronic kidney disease can be caused by surgery or trauma or diseases like diabetes or hypertension. Could be caused by pregnancy or toxins or even other issues. So the main thing to know is that you can't assume any relationships between these diseases or any other issues chronic kidney disease except for this. If the patient has hypertension and they have chronic kidney disease, and the chronic kidney disease is not attributed to anything else, we are to assume the relationship according to ICD-10 guidance and code that problem to I-12 category, which is hypertensive chronic kidney disease. In other words, if you don't know anything else except they have hypertension and they have chronic kidney disease, and that chronic kidney disease is not attributed to any other problem, you are to assume they are related and code that to category I-12. You're going to find chronic kidney disease classified to the N18 category. Guidance at N18 tells the coder to code first any associated diabetes or hypertensive chronic kidney disease. And then you'll also see guidance to use additional code to identify the kidney transplant status if that's applicable as well. Now, speaking of kidney transplants, if you have a patient who has chronic kidney disease and they received a kidney transplant, know that that patient might still have some form of chronic kidney disease, as that transplant may not fully restore all kidney function. For that reason, don't assume chronic kidney disease after a transplant is a complication of the transplant. Complications are issues like rejection, so you'll need to make sure you query the provider if you have questions as to whether or not this chronic kidney disease is a complication or it's just left over after the kidney transplant. And make sure that you also code the proper Z code for kidney transplant status in addition to the chronic kidney disease stage in those patients, okay? All right, time to hit the track and practice what we've learned. For practice number 1, your patient is referred for nursing care of the infected colostomy site with cellulitis of the abdomen as well. The patient also has benign prostatic hyperplasia with post-void dribbling incontinence and CHF. In this case, the colostomy infection K94.02 goes first. Then you will notice there's guidance at K94.02 that tells you to sequence next the cellulitis, L03.311, cellulitis of abdominal wall. Your patient also has enlarged prostate with lower urinary tract symptoms, N40.1, and you'll notice there's guidance there that tells us to use additional code to specify what the LUTs are, and that code is N39.43, post-void dribbling. And then finally, you have I50.9, which is your heart failure unspecified. Practice number 2, your patient's admitted for incision care, teaching and training, following surgical repair of an abdominal hernia. The patient also has chronic obstructive bronchitis with a frequent cough and was exposed to tobacco smoke while working for years as a bartender. Her incision is without complications, but she will need teaching on proper cough technique after surgery. She also has chronic constipation and generalized weakness, so she's going to need some teaching as well as that incision care and assessment. So in this case, you have in M1021A an aftercare code because there are no complications of surgery. The surgery resolved the abdominal hernia, so for that reason you have Z48.815, encounter for surgical aftercare following surgery on the digestive system. That's your primary diagnosis. Your second problem, which could be related to the surgery, is K59.00, constipation unspecified. That might actually be more acute because of the narcotics the patient might be taking after surgery. If that's the case, you're going to sequence it higher than the other issues. If the bronchitis was a problem, you would put that higher than constipation. So you can sequence those according to acuity, in other words. All right, the third place, we have J42, unspecified chronic bronchitis. We have directions at J42 that tell us to use additional code to identify any smoking or exposure to tobacco smoke, and we did. So for that reason, we also list Z57.31, occupational exposure to environmental tobacco smoke. The patient also has weakness from both the surgery as well as the long-term Respiratory issues, we're going to choose R53.1. In this case, this is more of a generalized weakness and not a true muscle weakness that you get with musculoskeletal diseases. That's why we chose the R code. And last, you have Z48.01, encounter for change or removal of surgical wound dressing. Now, when you're coding dressing changes, as we talked about in the webinar that had to do with wounds, you will only code dressing changes if it's for aftercare or routine care. When there's a complication, you do not code dressing changes for complications, okay? So in this case, it's routine aftercare. We do need to go ahead and add the surgical dressing change, and that will go at the bottom. We're not there to change the dressing per se. We're there to assess the patient's reaction and aftercare of the surgery. That's what we're really there for. All right, number 3, practice scenario. The patient is being admitted following recent diagnosis of Crohn's disease of the large and small intestine with rectal bleeding. He continues to have pain and diarrhea as well as weight loss, and so nursing is needed for diet teaching and new medication teaching. In this case, it's very simple. All the symptoms that we have are directly related to the disease process. Therefore, the only code we have in this scenario is K50.811. Scenario number 4, your patient is referred for IV antibiotic therapy for 3 weeks related to a urinary tract infection with E. coli that is resistant to most antibiotics. She has a PICC line in the right antecubital vein and will require dressing changes to the PICC line every 3 days and PRN dislodgement. The patient also has neurogenic bladder and incontinence without sensory awareness due to an old stroke. Now, in this case, we are going to code the urinary tract infection. That's the primary reason for home care, and that code is N39.0. There's a code there's guidance that tells us to use additional code to identify the organism, and for that reason we've listed B96.20, unspecified E. coli, as cause of disease classified elsewhere. Now, we had in our scenario that this particular strain of E. coli is resistant to most antibiotics. It didn't say MRSA particularly. So for that reason, we have to add a status code, Z16.24, resistance to multiple antibiotics. And you'll see guidance to do that when you get into the AB categories to use additional code to identify resistance to antibiotics. Now, she had a stroke years ago. She still has a sequelae of that stroke, and that is the bladder dysfunction. For that reason, we code I69.398, other sequelae of cerebral infarction. Other means we know particularly what the dysfunction is, but there is no code that covers that particular problem. For that reason, we have to list just after I69.398 what that sequelae is that is not listed. And so for that reason, we have N31.9, neuromuscular dysfunction of bladder, unspecified. And then we have N39.42, incontinence without sensory awareness. And we did that because there's guidance for N31.9 that tells you to code any associated incontinence. And that's what we've listed as the 1023F code here. And last, you have Z45.2, encounter for adjustment and management of vascular access device. And then you also would need to add the status code for long-term use of antibiotics. I ran out of room and it's not on my slide here, but you should have a Z code for long-term use of antibiotics as well. All right, practice scenario number 5. You have a patient who's referred following a right kidney transplant for hypertensive chronic kidney disease with end-stage renal disease. She will need incision care only, as this was a successful transplant. She will continue to require dialysis for a few months after the transplant, however. In this case, again, you're doing surgical aftercare. There are no complications, and that code is Z48.816, encounter for surgical aftercare following surgery on the genitourinary system. Then you're going to code the hypertensive chronic kidney disease, I-12. There's guidance at I-12 that tells you to use additional code to identify the stage of the renal disease, and N18.6 is end-stage renal disease. And then we also have to add 2 status codes. One code, Z99.2, is dependence on renal dialysis, and you'll see at N18.6 there's guidance to add this code if it's appropriate. And then last, we have to show that the patient has a kidney transplant status, Z94.0. Now, if you're still doing incision care at all, doing dressing changes, you would also add the code at the last code place for the change of surgical dressings. All right, practice number 6. Your patient's referred to home health following a recent diagnosis of stage 2 chronic kidney disease related to diabetes. He has had new medications added and needs teaching on these as well as diet. Now, the difference between scenario 6 and scenario 5, in scenario 6, the chronic kidney disease is directly attributed to diabetes. In scenario 5, it only stated that he had hypertension and chronic kidney disease. And when you don't have something else documented as the cause of chronic kidney disease and the patient has hypertension, you are to assume that they are related and code I-12 like we did in scenario number 5. In this case, the chronic kidney disease is related to diabetes. The physician has related those two, so it's going to be coded as a complication of diabetes. In this case, the 2 codes we have are E11.22, type 2 diabetes mellitus with diabetic chronic kidney disease, and then we have to add the stage N18.2, chronic kidney disease stage 2. If this patient also took supplemental insulin, you would have a code in the C position, the Z code for long-term use of insulin as well. Okay? And by the way, as we learned in one of our prior ICD-10 coding webinars, not every patient who takes insulin is insulin dependent. That's why you add the status codes for a type 2 diabetic. You don't automatically assume it's a type 1 diabetic because they're on insulin. And if you need to review that guidance, go back to our diabetes topic in the series that we have here for ICD-10 training, and we'll cover that extensively. In the meantime, I want to thank you for attending our Axxess ICD-10-CM coding webinar series. If you have questions before the next one comes out, or any questions at all regarding clarification of what you've learned so far, feel free to reach out to me. My phone number is here on the screen. It's 214-575-7711, extension 3917, or you can email me, and that's the best way to reach me, truthfully, as I travel so much. You can reach me at jgibson@axxess.com. Okay? Thank you again for joining us today at Axxess and for entrusting us with your education needs. And as I've always said on all the other webinars, I'll say again today, thank you so much for whatever you do at your home health agency, because I know if you weren't there to do your job every day, our patients would not be able to get the care that they deserve in the home, which is where they want to be. So thank you again very much for doing what you do every day to ensure those patients get the care they need. And thank you very much for visiting with us here at Axxess. We hope to see you again on subsequent topics. We still have to cover status codes, injuries and infections, and last in our 12-part series, you'll be getting an update as to what the coding changes will be coming for the calendar year October 2016 through 2017. Okay, so join us for the rest of our webinar series, and we will talk to you again soon. Have a wonderful day. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.